Up next, we have a thought leadership spotlight, and it's about something very important. It's about bridging the gap, evolving benefits to support women's health milestones. So whether it's starting a family or reaching a health milestone, women have long needed to navigate specialized care in kind of a silo, filling in care and knowledge gaps on their own. But as we look to the future of fertility and women's health benefits, we want to know, how can patient journeys become coordinated, digitally enabled, and personalized? So the goal is to address conditions and health needs that are both unique to women and present in women differently. So in this talk, Carrie DeChico, she is VP of Business Development at Progeny, will tell you what's next to evaluate the standard of care for women in the workforce. Please welcome Carrie to the stage.
All right, the mic is on. You can hear my voice. Hi, everyone. I have you for 20 minutes, so I'm going to try to get my slide up. So what I'm going to try to do is talk to you about women's healthcare in 20 minutes. And very important topic. One of the things that I think is most important is we kind of dial back, right? Everyone hears, women's health care. We have gaps in women's health care, but what does that really mean? It kind of, before we can go forward, let's give you a history of why we actually need to address these gaps. So everyone here has probably heard that women live longer than men, right? Sometimes a man says that. Well, my husband will say that when I'm really stressing him out, but it's true, we do live longer than men, but the flip side of that is that we spend 25% more of our lifetime in debilitating health. And one of the things that happens is it takes us a lot longer to be diagnosed with illnesses. There's not a lot of easy access to providers who specialize in female-specific issues. How did we get here? Well, started out, women aren't small men. You might have heard that as well, but the FDA did not agree with that. The FDA in 1977 banned women from being part of research. So anything that applies to a man, research-wise, applies to a woman as well. 1993, we're finally invited back in, which is great. So now we're included in research. But as of today, anyone want to guess what percentage of research dollars besides oncology go towards women? It's 1%. So we're happy. We're back at the table. However, we still have work to be done. And if you think about it, think about all the improvements in healthcare and research that went from 1977 to 1993. So we're very behind. It takes another 14 to 16 years for infertility to be recognized as a disease. And infertility, even when it's male factor infertility, the woman is the one that's going to bear the treatment for that. So again, anything that's really focused on women historically has been lacking. And we'll talk today about how these gaps affect 3 areas: fertility, pregnancy, postpartum, and menopause. And really, as we go through this, how does that impact employers? So think about it from a financial, lens, if you will. High claims, unnecessary claims, dissatisfaction. There's no way to navigate easily. And then what does that do for your culture? I've talked to a bunch of people who are in the DEI field. If you have any employee resource groups with women, you're going to see that it's very hard to focus at work, come back to work, and be productive. So we'll start with fertility care. Not surprising, we're having families later in life, so 1 in 6 people are going to need help conceiving, and that doesn't include those that are deemed socially infertile, so same-sex couples and single parents by choice. Because of the lack of research, we come to childbearing years with chronic conditions. So it takes on average 10 years for a woman to get a diagnosis of PCOS or endometriosis, which, when it goes untreated, really impacts your ability to conceive without assistance. If you think about what you go through when you're struggling to have a child, Most people say it's more stressful than a death in the family or divorce, but less than 7% of women are able to get support. So the gaps here really, we need to supply the right support. It needs to be done at the right time, and we need to be able to cover people for a full episode of care. Every other major medical condition isn't given the ability to, hey, employer, do you want to cover this? Or if you do want to cover it, do you want to just give maybe just $10,000 towards it? A full episode of care needs to be in place. And what would that look like? So those are the gaps. This is a way that we propose that you can solve it. So we'll use Jessica and Ashley here as our example. They're married, they want to start a family. It's a hard journey to start regardless, and if you're in a same-sex relationship, there's additional nuances. They're very lucky. Jessica's employer offers a benefit, and it is equitable, so same-sex couples can take advantage of it. They're assigned a patient care advocate. This is now their quarterback, and that person is going to be with them throughout the entire journey, help them find clinics that are appropriate for the type of care that they want. They're going to give them, the support emotionally. Are you ready, to start a family? Do you understand all of your different options? Help them make appointments, really guide them. Jessica and Ashley decide that they want to do reciprocal IVF. And this is where one woman donates her eggs, the other woman carries the pregnancy. And it's the best route for a lot of same-sex female couples. A lot of times, even if you have this benefit through a carrier, it's not covered because you have to have a medical diagnosis, which won't happen. This benefit that they have is giving them everything they need to complete this treatment from beginning to end based on their own unique situation. Just like we cover knee surgery, just like we cover anything else in the medical world. That broad brush where the FDA said, hey, anything that is researched on men, is good for women, that doesn't happen in fertility either. It has to be personalized. Their patient care advocate makes sure that, they understand what's happening. They have check-ins at certain points in time. Make sure everyone's taking their supplements. Make sure that the reproductive endocrinologist knows of any undiagnosed medical conditions. What are you going to do once the baby is here, et cetera? And so, happy ending here where they were supported all the way through and were able to have a child. But when you think about that again through the lens of an employer, loyalty for people who go through a fertility treatment and have a child, they stay with their employers. 80% said they'll stay as long as the employer will have them because they're so grateful. And you think about that also through the lens of DEI. It's a very connected journey, and we took the gaps out. Pregnancy and postpartum care. So the U.S. is not doing a good job taking care of pregnant women and postpartum women. For the last 3 decades, the maternal death rate has risen. We come into our childbearing years with a lot of these undiagnosed female-specific conditions, and that leads to premature births. We also have a lot of unmanaged fertility treatment that will lead to premature births. We're really doing a disservice to the BIPOC community, because there is a ton of research that shows that if we could do something as simple as give access to a doula, African American women and BIPOC women would actually die less as a result of pregnancy, childbirth, and postpartum. Simple as a doula. And then, as a country, we know postpartum is deadly, we know it's a problem, but we still put the onus on the new mom to reach out and ask for that help. And that's really hard because at that point, she's just trying to keep a 7-pound human alive, right? Trying to find time to shower, trying to find time to eat. So it's very disconnected. What we want to solve for here is early support. Engage a woman right when she learns that she's pregnant. And have proactive care. Don't put the onus on the woman to try to navigate everything. And it needs to keep going, right? It doesn't end once the baby is delivered. So what would that look like? We'll look at Katie here. She's going to be our member. She just had her first child. She, like most of us, waited. She had her child in her 30s, and she went through fertility treatment. The pregnancy and the birth were fine, but in the back of her mind, she's kind of waiting for the other shoe to drop. She still has a lot of kind of unresolved anxiety. Her partner's gone back to work, so she's at home with the baby. The baby isn't behaving like she sees babies behave in the diaper commercials. This baby is not breastfeeding correctly. It's not sleeping. And so she's worried she's doing something wrong. There's something wrong with the way I'm being a mother. So again, with the program, we get them connected to a patient care advocate. So this patient care advocate has been with her through her fertility treatment, stays with her. So she knows her entire story, knows her background. It's a trusted resource, but she's going to bring in a pregnancy coach as well. So her PCA calls her after delivery, checks in, how's everything going, kind of explains, here's what's happening, tell me, I've known you for 9 months, tell me what's going on, what do you need help with? So Katie's able to tell her, hey, I haven't showered in 4 days, I'm eating popcorn for dinner, the baby cries a lot, I think I'm doing something wrong. She gets some support. Almost half of the women skip their first postpartum visit. And that's at 6 weeks, and that is significant. It needs to happen. So Katie's PCA is going to say, hey, I know that next week is your postpartum visit. It's at this time, right? Okay. Do you have any questions? You want to ask about this, that, the other? Katie's, nope, I'm good. So her patient care advocate has it on her calendar, calls her back the day after Katie's postpartum visit. Katie didn't go, because the baby didn't sleep that night, she's exhausted, and there's, it's wintertime, the flu's going around. If she leaves the house with the baby, they're gonna get sick. So this is a red flag. So at this point, her patient care advocate knows what benefits Katie has through her employer, and she pulls in a mental health coach from the insurance carrier and says, this is an issue, we need to reschedule. I'm going to reschedule that for you and make sure that you attend this. And we really need to increase the outreach, because I'm talking to you once a week, I want to talk to you twice a week until we get through this critical time. So that's nice. She didn't have to go out, ask for mental health support. She's able to get it, and she's able to rely on someone to help her through this. As she gets closer to return to work, her patient care advocate helps her with that. So she has the ability to go back on a schedule that really works for her family, takes the stressors out of it. And, if you again think of it from the employer's standpoint, if you have someone engaging with a fertility patient, those patients are automatically high risk, just because usually it's an older maternal age. But we've had them engaged from the beginning, so now we can make a difference in the outcomes. There's not going to be any maternal mortality issues. There's not going to be any preemies, because we're able to manage that process. So you can think about what that would do as far as unnecessary medical claims to your plan. Also think about getting women to return and being very productive when they come back to work. It's huge, retention. So I will go on and, kind of feels, anyone else feel like super really hot all of a sudden? No, it's menopause, don't worry about it. So my friend menopause, this is the last one we'll do. Save the best for last here. Probably if you're sitting in this room, you've heard the word menopause more in the last 2 years than you've ever heard before, which is good, because boy, do we have a lot of work to do here. If we didn't have research before 1993, we're playing catch up here. So there are 36 different symptoms that can be associated with menopause, not just, the common popular ones, but things like joint pain, heart palpitations, your heart starts racing. And if you have an employee that comes into your office and says, my heart won't stop racing, you're going to tell her to go to the ER. The cardiologist is going to see her and say, I don't know what it is, let's refer you here, here, and here, not even thinking that you're 37 years old and this is perimenopause happening. So on average, almost 47% of women, it takes them 15 different provider visits before they get a diagnosis of perimenopause or menopause. I learned a new word, it's called poly shopping, and that's exactly what that is. And these are the women, if you think about it, that are probably, they've been in their career for a long time. So they are probably at a level in management where they're very valuable. You want to retain them, but you don't want them to come to work worrying about, I'm going to get sick in a meeting sitting next to my boss. And as women, we're usually told, anything, go see your OBGYN. But they are trained to have a healthy mom and a healthy birth. Less than 7% of the OBGYNs in this country get any training at all in menopause. So where do you go? The gaps here are you need to get to the right provider. There are menopause specialists, and you want to get there fast so you can get symptom relief. All the coaching in the world, is not going to give you symptom relief. And then we need to keep having the conversation. We'll talk about Nicole here. So Nicole, she's 42. She's kind of, living the whole dream. She's a working mom. She's high up in her company. She has the classic symptoms. She's getting hot flashes. She can't sleep at night. And she has 2 toddlers. So why would she ever think about menopause or perimenopause? She went to her primary care physician because it's becoming a problem. And again, 42, primary care physician's not going to think anything about that. So she feels dismissed. He's like, well, maybe we'll do blood work. And she's really busy. She doesn't know how to research these symptoms. If she's having heart palpitations, she's going to think, oh my God, I need to go see a heart doctor. Do I have a history of heart disease in my family? Her employer offers a really cohesive benefit. So, when she's looking at open enrollment, she's like, oh, well, 36 symptoms, I'm having some of these, let me just give them a call. She gets assigned a patient care advocate. This patient care advocate listens to her and says, you know what, it might be perimenopause. Why don't we get you a virtual appointment with a certified menopause specialist? And let's let the experts take a look at this. So she does. She receives an assessment, and lo and behold, yes, she has entered perimenopause. What this doctor can do for her is talk about her symptoms, talk about how to get symptom relief, because that's what we want, right? We don't want just the coaching. We want to feel better. And they can prescribe medication if it's needed. If you try to see a certified menopause specialist in person, it's a 5 to 6 month wait on average. She's able to get in within a week, and they'll also talk to her about things like nutrition and lifestyle changes. So she has ongoing care. So that's great. We've got your symptoms under control, but what else comes along with our friend menopause? Now you need to start thinking about colonoscopies. Now you need to start thinking about mammograms, and really just looking at this stage of life and diagnosing and treating immediately. And again, from an employer's standpoint, 15 different office visits to get a diagnosis, that's a lot of unnecessary medical claims. And think about these women and retaining them. If they have been with you since, they started their career, you want them to stay and you want them to be productive. And that is what, when we close the gaps in menopause with the right care, with the right specialist, that's what's going to happen. So how do you do it? Easier said than done, right? It's very important, and why we're talking to employers is because half of a woman's health life cycle is spent while she's in her career stages. So employers have a really big opportunity to make an impact here. And I would just say, when you start looking at your benefits and thinking about them, there's so many solutions out there and they all sound great, and pet insurance and whatever else it is, but really think about, what gaps do I have and how can I close those? Because when you close the gaps we just touched on, you're going to see that financially it's going to make sense. It's going to make sense culturally. Proactive support. Everything we talked about here had a proactive aspect to it. Don't put the onus on women to navigate a system that, the healthcare system wasn't created by or for women. We need to make up for that lost time when we were not allowed to participate. And then choose equitable coverage for everyone, and make sure it's intentionally designed for the specific concerns of women. Oh my gosh, I ended right at 0.00. Thank you very much.